We are live. We are live.
Yeah, okay. So I'll just wait for the participants to like start coming in, and I'll wait for a minute and then we get it's 6:59. So I'll wait for a minute and then we get started. Good evening, all our attendees. I'm Shriyal Sethumadhavan, the Executive Editor of Aesthetic Medicine India, and I welcome you all to the Aesthetic Medicine Digital Series. We have with us this evening Dr. Anil Ganjoo. Uh, he would be our esteemed speaker for this evening, and his session will focus on fractional resurfacing evolution, CO2 fractional to nano fractional RF. Dr. Anil Ganjoo, can you join us, please? A very good evening and warm welcome. Thank you for joining us today. So I'll take this opportunity to introduce Dr. Anil with a few more words. Dr. Anil Ganjoo is a senior consultant dermatologist and laser surgeon and the director of Skinnovation Clinics. He is the recipient of the prestigious Dr. Sardari Lal Memorial Lifetime Achievement Award, awarded by the Indian Association of Dermatologists, Venereologists and Leprologists, Delhi State Branch. He was bestowed upon the rare honor of being the visiting dermatologist to the former President of India, Dr. APJ Abdul Kalam. He heads the Departments of Dermatology in several prestigious Delhi institutions. He is the current president of SAARC Association of Aesthetic Dermatology and past vice president of IADVL National and the past president of IADVL Delhi State Branch. This plus, he has trained many young aspiring dermatologists. Thank you once again, sir, for joining us today. Before I get you to take over this session, a few details for all our attendees who've joined us today. If you have missed any of our past webinars, all you need to do is log on to our website, aestheticmed.in, for the recorded sessions. Today, at the bottom of your screen, you would see two options. One is a chat box and one is a Q&A box. Please feel free to leave your suggestions in the chat box on webinar topics that you look forward to or any expert that you want to hear through our sessions, as well as your feedback for today's session. For any questions that you may have for Dr. Anil for today, please key them into the Q&A box and he will take them up at the end of the session. So the chat box is for your feedback to us and the Q&A box is for your questions to Dr. Anil. And with that, over to you, Dr. Anil. I would be putting my video off now. You could share your screen and I would join you back at the end of the session.
Okay, thank you, Shriyal, and thank you for this opportunity to get connected to so many people at the same time. Just sharing my screen. So today we shall be looking at how fractional resurfacing has evolved over the years. We started with resurfacing of the skin using our conventional carbon dioxide laser way back around maybe 15 years. And since then, there have been so many things happening in this world of resurfacing. We have evolved into fractionation. We have evolved from lasers to energy-based devices, and those energy-based devices have evolved, into newer kind of machines. All this has been happening because there has always been a quest to develop newer and newer technologies that would be associated with lesser side effects, but at the same time we would get outcome or results equivalent to the conventional lasers that we would use earlier. Now, if we go back to the conventional carbon dioxide ablation and resurfacing, we would get fairly good results with that, but it had its problems. So, for example, this patient who was treated for these abrasions on the nose was given a spot dermabrasion on the nose, but the problem thereafter would be that there will be a long post-operative period, and healing would take about maybe 2 to 3 weeks initially for the epidermal layer to come back. And then there would be lots of problems staying, like lines of demarcation, scarring, dyschromias, side effects, particularly in the dark skins like the hyperpigmentation, which although is temporary and can be taken care of with various agents, but then it would happen and would have a huge impact on the patient's psyche. More than the pigmentation, lasting erythema for months together would be a huge problem in these patients. There would be curtailment of their social activity. Contact dermatitis was common because you would thin out the skin and allergens could penetrate into the skin easily. And if you acne and melia would happen because of the procedure as such, and also because of the medication that we would use after that procedure. And if you would be aggressive in your treatment, you could produce scarring like both atrophic and hypertrophic. So some of the results, this was a trichoepithelioma on the nose, completely cleared with just one session, scars on the nose, completely cleared with one session. But then we had problems. So because we had to be very careful in the post-operative period while the patient would heal up. The patient would have to, curtail activity, not go out in sun for several months. Erythema would sometimes stay for several months, and then that was the problem. So in came fractional resurfacing, which was a technology where both ablative and non-ablative lasers would get an attachment of a fractional scanner at their handpiece, so that we would treat only a fraction of the skin while the whole skin was exposed. So the intervening areas would be left alone and untouched, and they then would repopulate these ablated columns of tissue. So this was fractional resurfacing. At each pass, we treat about 15 to 25% of the exposed area. So what happens is that we create these high precision micro beams in the laser beam, which penetrate deep into the skin and create narrow, deep columns of tissue coagulation. These are known as MTZs, or microthermal zones. The depth of a microthermal zone would be proportionate to the energy that you have used. So the more the energy, the deeper you will go. And then coagulated tissue would initiate a healing process. There would be myofibroblasts being stimulated. There would be neovascularization and neocollagenosis. All this would lead to some amount of resurfacing, some amount of textural improvement of the scars and the skin as a whole, and mild to moderate improvement happening at each sitting. 4 to 5 sittings would give us a fairly good result, comparable to about one sitting of a conventional laser. So this was not as effective as conventional lasers, but then we would overcome the side effects that were associated. This is a diagrammatic representation of what I've already told you. And fractional scanners can be attached both to ablative and non-ablative. So all lasers are now coming with fractional mode. We have the CO2 laser and the erbium YAG amongst the ablative fractional lasers, and we have the Nd:YAG 1320, the diode 1450, and the erbium glass 1540 amongst the non-ablative fractional devices for resurfacing. Now, this is a histopathological representation of the depth of the MTZ depending upon the energy that you have used. So lesser the energy, as you can see on the left side, lesser is the depth of the MTZ, and more the energy, more will be the depth. In these diagrams, you will see that the epidermis is intact. It is not, severed as is seen in an ablative laser. A non-ablative laser penetrates just and into the dermis and creates these zones of coagulation within the dermis and nothing in the epidermis. So as we kept on doing this, we evolved, and we saw that in addition to the light energy devices, that is the laser, we could use fractional resurfacing in the energy based devices like the radio frequency device. And the radio frequency device came in with the microneedle radio frequency, then later sublative, later nano fractional lasers, and now there are further newer generation fractional radio frequency devices. I'll tell you about those in a little while from now. So what did we do with these non-ablative fractional lasers? We started resurfacing with non-ablative fractional lasers way back about 15 to 20 years back, and this was the one that we used. This was a erbium glass laser which had this it was a fractional laser, and then we evolved, got more erbium glass fractional lasers which had cooling tips with them. Uh, the advantage with these lasers was that the downtime was very, very less. So as you see, immediately after the treatment, there is no ablation of the skin, there is no denuding of the skin. There's a little bit of erythema and edema that has happened. This will last for about maybe 3 to 4 days max, and the patient is back to work within 24 to 48 hours. So, and sun exposure, although is to be avoided, but is not a huge concern as is with the ablative lasers. I'll tell you later on. So a subtle improvement would happen after 3 to 4 sessions. As you can see in this patient, the other profile, some improvement happening again in another patient. Then we evolved into the fractional CO2 laser. There was always an apprehension that darker skins, when treated with ablative lasers and ablative fractional lasers, would be more liable and are more liable to produce post-inflammatory hyperpigmentation. There are a lot of studies which say that we should be very, very careful in our kind of skins. But then practically speaking, we have not seen a huge problem happening with ablative resurfacing lasers. We have used carbon dioxide fractional laser in many of our patients, although we do come across PIH. But if you're careful, if you prime your skins properly, and give them a proper regime following the treatment with CO2 fractional, then usually post-inflammatory hyperpigmentation is not a problem. So the fractional CO2 laser, the histopathological diagram on the right side will show you that causes a complete ablation of the epidermis, the dermis, and down into the deeper dermis. While as the non-ablative erbium glass, for example, or a non-ablative Nd:YAG would cause coagulation within the within the dermis only and leave the epidermis intact. So the advantage here is that post surgery or post-procedure downtime is less. The patient does not take much time to heal, can go to work within 48 to maybe 72 hours. But here in CO2 laser, the downtime is more. If we compare two ablative fractional lasers, the CO2 and erbium YAG, although the erbium YAG is very precise and the absorption in water of the erbium YAG is about 18 times more than CO2 fractional. But the problem with erbium YAG is that it is very precise, can't penetrate very deep, and does not cause a lot of coagulation in the surrounding area. While as the CO2 causes a lot of coagulation in the surrounding area, which means that you are heating the skin well, and this causes a little tightening of the skin also. So the CO2 fractional has an advantage of, in addition to treating the scar, it causes some tightening of the skin, which I'll show you in my experience that I've had with my ablative lasers. So the ablative lasers produce something like this immediately after treatment. Those CO2 laser treated patient So this patient is to be, number one, primed properly before we treat him, because he's more likely to develop post-inflammatory hyperpigmentation. So you have to be careful that you prime this patient, you give a good regime of sun protection, etc., after the treatment. And then this patient has to be ready for downtime. If your patient is not ready for downtime, then you better do a fractional, non-ablative fractional laser, which has its disadvantages. I'll tell you in a little while from now. So this is what it will look like immediately after treatment. There'll be edema, erythema, and then this grid pattern of crusting or these frosted spots on the skin. Now, these will give way to black crusts, which will develop over 2 to 3 days, and then these crusts will fall off in about 6 to 7 days, and by 7 to 10 days the patient will be back to normal. And it's very important that during this 7 to 10 days the patient has to be extra careful not to expose to sun, and keep on moisturizing the skin properly so that it heals as early as possible. And PIH is avoided, and PIH particularly can be taken care of if you have given a good priming to the patient. The patient has been given some depigmenting agents before the treatment, and then sunscreening is done properly, and he's given a good counseling on that. But ablative fractional lasers, we saw that gave us much better results than non-ablative lasers. You can see this patient who underwent 1 session of subcision and then 4 sessions of CO2 fractional, and you can see how much he has improved on both sides of the face. Similarly, this patient, after 2 sessions in the middle, here, and then after 4 sessions, doing quite well. A patient of post varicella scars, you can see here and here, almost vanishing with just 2 sessions of CO2 fractional. Another scar here, almost you can't see it in this nasolabial fold, as you could see here. So this is post varicella scar also disappearing. Another patient of post acne scar, showing improvement not only in the scars but also in the skin pores. A post surgical scar and post trauma scars do quite well with CO2 laser. You can see after 4 sessions the scars have almost vanished. So several scars, this is the major scar which has gone considerably less, and the rest of them have become much better. A post surgical scar, you can see after about 2 sessions, has improved considerably. Post inflammatory hyperpigmentation, as I was talking about, can happen, and you have to keep your patient and warn your patients about the possibility. This patient, for example, underwent 4 sessions of CO2 fractional. The scars have gone wonderfully well, but then PIH has developed. But we as dermatologists are equipped well enough to take care of this PIH, and we can deal with it with our medication, with our chemical peels, and sometimes with something like laser toning, etc., with the CO2, with the Q switch laser. So we have to be aware of the possibility of PIH. We have to tell our patients about the possibility of the PIH, but that should not deter us from using good amounts of energy and good parameters for treatment of scars. So because scars will respond only if you cause enough heat in the skin and you stimulate the fibroblasts good enough. Another possibility, another problem is that many times the patients are not satisfied with your results. So photographic record is extremely important. This patient particularly came in after 4 sessions and tells me that, doctor, my parents are telling me that you wasted all your money and there's no improvement at all. So what she needed was just a before after. And you can see at this stage, after 4 sessions, she told me that she has had no improvement. And then she was shown these serial photographs, and then she was really convinced, and she wanted this before after picture to be shown to her parents, who then were convinced that she had done fairly well. This is the other profile of the same patient. As I told you, CO2 fractional has the advantage of causing coagulation around these MTZs. This coagulation induces tightening in the skin. You can see some filling effect in the skin also, which has happened in this patient. In addition to the scars that have improved, there is filling effect. The hollowness of the cheeks has also gone to some extent. You can see the improvement in the hollowness, the scars, etc. comparing the non-ablative versus the ablative, there was this review article that appeared in the British Journal of Dermatology in 2012, where they had compared the results with ablative fractional photothermolysis against the non-ablative photothermolysis. And they definitely saw that efficacy-wise, the ablative fractional photothermolysis was much better than non-ablative. But the problem with ablative was the PIH, which could happen, the discomfort, erythema, and the downtime that was present. So if your patient is ready, to take that downtime, and if he is counseled properly, if he is prepared properly, and if he follows a good regime, I think ablative fractional lasers are a better choice to go. Now, after we have discussed the the lasers for resurfacing and fractional resurfacing, let's move on to energy-based devices. There was this article which appeared in 2009 in Laser Surgery and Medicine by Hantash et al. What they did was that they first time used a bipolar microneedle radiofrequency device. So what they did was that they introduced needles into the skin with a positive and a negative electrode. They passed electric energy into the positive electrode, and that traveled to the negative electrode. And while this energy traveled from positive to negative, there was impedance provided by the skin, where heat was created, and this heat led to stimulation of the fibroblasts to produce collagen. And this led to resurfacing and improvement to a large extent. The advantage here is that we don't have to depend on an energy which is sprayed onto the surface, and we don't know how deep it will go. And usually the lasers do not go as deep. Here we are going deep down into the dermis, and after going deep down in the dermis, we are further going deeper by releasing this energy from one electrode to another electrode. So let me tell you, when energy travels from one electrode to another electrode, it does not travel straight like this. It travels like a wave and goes down. So, and the distance between the electrodes will determine how deep it will go. If the electrodes are far off, then it will go deeper to travel to the negative electrode. If they are nearby, then it will not go as deep. So this is important also because newer technologies are employing this idea of distance between positive to negative electrode to increase the depth of entry of this energy into the dermis. So the advantage is, first, the needle goes, you have gained a depth of about 1.5 to 3, depending upon the depth of where you want to reach, and then you can go further deep by increasing the distance between the electrodes. So that is the beauty of the microneedle RF and the radio frequency devices. So this is a diagrammatic representation of what I told you. A needle will go into the skin, deep down in the skin, and these are two types of needles, insulated and non-insulated. I'll tell you what the difference is. An insulated needle will have an opening only at the tip, lower tip. It will enter into the skin and deliver energy at the tip, and from here it will travel to the negative electrode. So the intervening skin is left alone. So no damage done to the upper dermis, no damage done to the epidermis. So the downtime is extremely low. There is no effect on the superficial surface of the skin at all, and the patient gets a good enough effect. Also, the time for which the electrical energy is delivered into the skin will determine the amount of coagulation that you will produce within the skin. In this diagram on the right side, you will see, as we increase the duration of release of energy from 0.1 second to 0.2 to 0.4, you will see that the amount of coagulation produced in the surrounding skin increases. So the duration of delivery of energy will determine how much coagulation you will produce within the dermis, and that will finally determine your outcome of the resurfacing procedure. Now, compare the insulated versus the non-insulated needle. So this is an insulated needle which will go down into the skin, deliver energy only from the tip. 100% of the energy is delivered from here. Positive goes to negative. But a non-insulated needle penetrates into the skin because it is non-insulated. So the energy travels from positive to negative throughout the length of the needle. And thus, there is coagulation produced not only at the lower end, but also in between and also in the epidermis. So downtime is a little more, but coagulation is better. Also, it has been seen that there isn't much difference between the insulated and the non-insulated needles, because in insulated needles, because of the thin tip at the lower end, the maximum energy is delivered here at the lower end only. And it has been seen that about 80% of the energy is delivered here and only 20% of the energy is delivered in the upper part Here, 100% energy is delivered here. So this has the advantage of lesser downtime, lesser discomfort, lesser PIH, but this has the advantage of more coagulation because it happens throughout the skin. Okay, so let us look at our experience with microneedle radiofrequency. We've been using this device for our microneedle procedure, and we've used it for multiple indications. For example, this indication, which is a difficult indication generally, and requires many times, combination of several procedures like peels, like, microneedle, derma rollers, microneedling, etc. We combine everything. But in this patient, you can see what happened immediately after the treatment, lot of edema. That means you have caused enough heat and coagulation within the dermis. And you can see after one session, there was considerable improvement, particularly on this side. MNRF, we saw that is a shade better than even carbon dioxide fractional. I told you we evolved from non-ablative fractional to ablative carbon dioxide fractional, and then to energy-based devices. So MNRF, this patient, for example, had undergone 4 sessions of CO2 fractional, had improved to a good extent, but then we wanted further, and he was not very happy. His skin was very thick, his scars were quite deep. So we took him up for MNRF, and 2 sessions of MNRF gave him fairly good improvement, as you can see. Another patient from CO2 to MNRF doing well. I'll be talking about nano-fractional radiofrequency in a little while from now, but this patient again is a sequential treatment where she had undergone 4 sessions of nano-fractional radiofrequency, which is a more superficial treatment. And then after not getting very good response with NFRF, she went to MNRF, and 2 sessions of MNRF lower down from here to here. You can see complete clearance of scars with just 2 sessions of MNRF. So NFRF giving good response, but MNRF giving the final improvement. So combination of lasers at the same time or sequentially sometimes can also, help you give further better response. A good response, 4 sessions of MNRF requires further treatments. We can wait for some time. Usually after 4 sessions of fractional resurfacing, we give some time for the fibroblasts to do their work, and then do further sessions maybe after about 4 to 6 months. So another profile of the same patient. This is just one MNRF session. A patient of a melanocytic nevus removed from the nose, a scar left, and then 2 sessions of MNRF improves the scar considerably. Now, after the microneedle radiofrequency, let's move on to another radiofrequency fractional resurfacing device called the sublative radiofrequency. Now, what is sublative? Sublative means that you do not produce ablation at all. You do not send needles into the skin. You just place electrodes on the top of the skin. And from these electrodes, as you can see in this diagram on the left side, electric energy travels from the positive to the negative electrode, and this causes heating up of the tissue. The distance between the electrodes here becomes very important. The more the distance between the electrodes, the deeper the energy travels and deeper you would go into the skin. One very important point to note here is if we compare the laser devices providing resurfacing versus these energy-based devices providing resurfacing, the lasers produce maximum damage at the uppermost layer of the skin, that is epidermis, where we don't want them to produce maximum impact, and the minimum impact is lower down in the dermis, where we would have wanted more impact. On the other hand, the energy-based devices or electrical devices cause less damage at the upper end and more damage in the lower end where we want it to happen. So that is the advantage of electric devices or energy-based devices. They cause more damage to the dermis than to the epidermis. Now, the nanofractional radiofrequency was a new concept that came about a few years back, where it was a smart scan technology where you would play around with the parameters to produce ablation or coagulation depending upon how much of each one of it you would want. So depending upon whether you want to treat the scars only, then you would produce more ablation, or if you want to cause tightening of the skin, then you would produce more coagulation. If you want both of them, then you can have high ablation, high coagulation. So these machines basically have the ability of producing, changing the energy concentration so that you can go deeper into the skin. So higher energy will give you more coagulation, and the longer duration of delivery of this energy will give you more coagulation around the treated area. So a young scarred skin will be treated with high energy so that you go deeper down, produce more ablation, do not cause a lot of coagulation. But older skins, loose skins would be given longer duration of this energy so that tightening of the skin occurs. So that is the advantage, because you can play around with both these. So some of the results with NFRF, this is, by the way, my side profile, 2 sessions of NFRF. This is nanofractional radio frequency, produced considerable improvement in the right teats. This is about 3 or 4 years back. Another patient, road traffic accident, treated with a good result from the plastic surgeon, but not good enough to take care of the scar. And you can see how the scar has gone with just nanofractional radio frequency, no other treatment. Another patient of acne scars, a pre-sternal keloid that I treated was not doing well with only intralesional steroids. So we combined it with nanofractional RF, and you can see the result. Recently, there is another introduction in the radio frequency resurfacing, the 4th generation fractional resurfacing, they call it. I've just got it into my clinic. It's called switching vacuum cooling technology, or the SVC technology. So what it does is, I talked about the distance between the electrodes making a difference in the depth of the impact of a machine. Now this device, particularly called Viora, has a handpiece and a plate which has all these electrodes. They are not needles, they're just electrodes, which has all these electrodes distributed on top of it. There is one line of positive electrodes, there are several lines of inactive electrodes, and there are several lines of negative electrodes. Now, depending upon the depth that you want to go into the skin, for example, if you want to go shallow, then you deliver energy from the row 1 to row 3. If you want to go midway into the dermis, then you deliver energy from row 1 to row 5. If you want to go very deep into the dermis, then you deliver energy from row 1 to row 8. So as the distance between the electrodes increases, the depth of energy will increase. So in this machine, you have the possibilities of going shallow, medium, deep. You can do all the levels in different passes. So that combination gives you a wonderful effect. Another good thing about this machine is that it has a vacuum at the top of this piece, which pulls up the skin into this vacuum and then delivers energy very uniformly and quite deep into the skin. You can see how beautifully it has distributed the energy. One more important good thing in this SVC technology machine is that it has these smart heat electrodes which preheats the skin before delivering that fractionation. So preheating reduces the impedance in the skin, or the electric resistance within the skin, so that the energy flows very easily. You require lesser amounts of energy to produce similar amounts of results. So it becomes safer, it becomes less painful and comfortable treatment. So to conclude, friends, scars of varied origin, including acne scars, surgical scars, stria, etc., have been a huge challenge for us cosmetic surgeons. Lasers have provided a great help in this field. And this resurfacing has evolved, as I told you, from conventional carbon dioxide ablation to non-ablative lasers, to then fractional lasers, both ablative and non-ablative. Then we went on to energy-based devices like the MNRF, the NFRF, the sublative RF, the SVC technology. All of them, we are evolving, and we are evolving so that side effects become less. I talked about all these technologies. The best results you get if you combine it with other techniques. For example, for rolling scars, you do a subcision, then do resurfacing. For a ice pick scar, you do a cross technique and then do subcision. For a very deep box scar, you will either remove it, for example, do a excision, punch excision, stitch it, or maybe you can, do feathering of the edges and do a subcision of a deep of a box scar and then resurface. So if you combine all these techniques, you are going to get very good outcomes. So the need is to use your procedures judiciously, decide what kind of scar you are treating, employ a pre-resurfacing procedure like cross resurfacing, derma roller, peels, etc., and then do your resurfacing. Combine it with peels to take care of the PIH and other post-inflammatory problems, and then get the best results for your patients. Thank you very much, friends. I hope I could convey this journey that we have had, in the evolution from conventional fractional lasers to the present day energy-based fractional electric devices. So I'm stopping the presentation here, and we are going to take up questions if we have. I'm going to the question answers. I think we have 6. Okay. Swarnlata Kotian ji is asking Dr. Ganjoo, by when timeline would you see patients becoming comfortable for aesthetic procedures in this COVID-19 era? Okay, this is besides. Uh, More than patients becoming comfortable, we have to be comfortable. Although there are a number of guidelines that have been laid down for doing procedures in the COVID era, it's not very easy to follow those guidelines and do these procedures. We are trying to apply these guidelines. We are trying to cope up with how we will do these procedures. It's becoming very, very difficult. Wearing PPEs and doing procedures almost impossible. We are looking at wearing respiratory masks. We are looking at smoke and virus excavators from the area that we are treating. We are looking at how we protect ourselves from the patients. Patients may be asymptomatic, and you never know, they might be carriers. So it's a very difficult situation. We have not been able to fully figure out how we are going to do it, but we are trying to look at it. Dr. Uddhav Patil, good evening, sir, from Mumbai, is asking what cream regime you advise post-fractional CO2 resurfacing. Okay, these patients generally do well with good moisturizing creams, particularly those that contain hyaluronic acid, which has a good hydrating. We basically have to give them good hydration and protection from sunlight. That is fairly good. I avoid steroids. I avoid antibiotics, which can cause contact sensitization, because these skins are already ablated and compromised. So best is give a good moisturizing cream, a lot of hyaluronic acid, and a good sun protection regime. In addition to the sunscreens, you have to tell them not to expose to sun for at least 7 to 10 days until the skin heals completely. Tanvi Komavar is asking acne scars, which gives better results between fractional CO2 and MNRF. Do we choose it depending on the age of the patient? Okay, both have their advantages. If you have very deep, I showed you a patient who had done CO2 fractional laser 4 sessions, had not done very well, and 2 sessions of MNRF did very well. But that doesn't mean MNRF is the ultimate answer. It will depend upon what your patient has. If the patient has very superficial scars, then CO2 fractional will be a good option. If the patient has very deep scars, then MNRF will be a good option. If the patient has both kinds of scars, then probably a combination will be a good option. The advantage of MNRF is that you can go deep down in the skin with your needles and then deliver your energy there, and which goes deeper down. So the depth is no bar for MNRF. So if you are treating a thick, severely scarred skin, MNRF is the answer. If you are treating a delicate skin with superficial scars, CO2 is the answer. I would say start with MNRF, treat the deeper scars. As the scars resurface, then do a final 1 or 2 sessions with CO2 fractional. That gives you a wonderful, combination of both of them. Tanvi Komavar again asks parameters that you prefer for acne scars in fractional CO2. Now this varies from machine to machine, but in general, you have to follow the principle of for treatment of scars, low density, high energy. So your density should not be more than 15 to 20% of the area covered, and your energy has to be high. So be aggressive, but be at the same time be careful not to be very dense, not to produce the microbeams should not be near to each other. While as when you are doing textural improvement or superficial rejuvenation of the skin, then the density can be high, energy has to be low. So these 2 parameters, if you keep in mind, I think that is good enough, and that you can employ in any kind of machine. Otherwise, they are different for different machines. Okay, Tanvi. Shraddha Samant asks, can a patient having a titanium plate for ASD almost 10 years ago undergo MNRF or CO2? I think either of the two do not have a problem, because MNRF is a bipolar device where electric energy is traveling from one electrode to another electrode, and CO2 does not go into the body at all. It travels only up to the some level in the dermis. But monopolar devices of radio frequency can have problems with the metallic devices, because the energy travels throughout the body. In those, you will have to be careful. Okay, Ina Jain, sir, what is the line of treatment for stria density? Okay. I showed you that these energy-based devices do give some improvement, but let me tell you that none of them alone gives 100% improvement. So we have used CO2, we have used energy-based devices, we have used fractional non-ablative devices. But if you combine your procedures, maybe derma roller, sublative RF, sometimes some peels, and for the white skin, maybe targeted phototherapy to cause a little bit of pigmentation. All this put together generally helps. So you need to combine procedures for stria. Okay. Divya Malhotra asks, which is better, ablative laser resurfacing or MNRF? Can we alternate laser with MNRF? I told you both have their advantages. Yes, you can alternate. You can get the best of both the worlds if you have both the machines. So treat deeper, thicker, scars and thicker skins with MNRF. As the skin scars become better, they resurface. Then you go to a CO2 fractional laser, which treats the superface. It gives you a sheen and gives a smooth texture to the skin. So if you have both, start with MNRF, resurface, then improve the sheen and texture of the skin superficially. How new fibroblast plasma pen works? Is it useful for Indian skin? I think you are talking about the derma pen. Uh, Derma pen is same as microneedling device, but a derma roller is not as precise. The derma pen has a very thin needles, and in addition to that, these people develop cocktails that can be given with these microneedling devices like derma pen, which have their ability to improve the final outcome. They have cocktails for pigmentation, they have cocktails for scar improvement, textural improvement, all of them put together. So that gives a good outcome. Dr. Uddhav Patil says, excellent presentation. Thank you very much, sir. That's quite encouraging from you, sir. Jaya Sharma ji, how many sessions of radio frequency required for stretch marks, energy, and gap? Any topicals required? Uh, as I said, Dr. Jaya, it has to be a combination. If you're doing resurfacing, do it once a month only. In between, maybe you can do a chemical peel, or you can do a derma roller and use some mesotherapy agents, etc. Or you can do. I have done in patients who have completely white stria. I have done targeted phototherapy also to induce some pigmentation that gives them at least a visual improvement, if not textural improvement to a large extent. Okay, Dr. Rashmi Badra asks, can we use any serums post MNRF like hyaluronic acid? Of course. Hyaluronic acid is a very useful hydrating agent, which not only promotes healing, but also leads to a good hydration of the skin, which prevents side effects, which promotes healing, etc., and the patient is back to normal quickly. Dr. Dinesh Havelia, my friend from Calcutta, hello sir, says that wonderful presentation as always, MNRF versus NFRF. Okay, Dr. Havelia is a very close friend. He has attended many of my presentations, and he says that as usual you are comparing the two. Thank you, Dr. Havelia. Dr. Sonal Singh says, good evening sir, what preconditioning creams are best? Okay, preconditioning creams for Priming can include creams that contain tretinoin, glycolic acid, kojic acid, etc. Or you can also use hydroquinone. Sometimes you can also use a triple combination with a very, very mild steroid like hydrocortisone for 2 weeks, 3 weeks prior to the session. There were several studies that we came across from the Far East, where they had used a triple combination 8 weeks prior to laser and a triple combination following a fractional laser. They found that rebound hyperpigmentation was much more if it was started later after the laser, and it was reduced to a considerable extent if it was started 8 weeks prior to laser. So it is recommended that in all our patients, particularly the dark patients, we should prime them. uh, Dr. Jimmy Thomas, what do you advise for post-burn scars? Post-burn scars, it will depend on what kind of scars you have. If you have atrophic scars, then maybe a fractional resurfacing device. If you have a hypertrophic scar, then intralesional injections of tricot mixed with sometimes 5-fluorouracil and Hylas. And we have also done fractional lasers on hypertrophic scars along with intralesional injections, and we found that the combination gives better results. And hypertrophic scars with a lot of erythematous content, pulse dye laser or one of the vascular laser, even IPL with the vascular handpiece combined with intralesional injections are very good. Dr. Natmal Kailash, which is the best and safe device during this COVID era? Okay, we are fighting this question all along, and we don't know. But procedures that do not warrant the aerosol, like if you can cover the mouth, nose, and eyes of the patient, and if you have to work away from the face, that makes it safer. And preferably ablative lasers that produce a plume. We are not sure whether they are safe, whether they contain the virus or not. Although the virus is present only on the mucosa, but then we are not sure. So as on now, all ablative procedures to be avoided. All procedures that are aerosol generating, like the ones that work when we work around the mouth, have to be avoided unless you can cover the mouth, nose, and eye properly. People have been doing procedures using special respiratory masks, which filters about 100% of the viruses, but they are quite expensive, about 2 to 3,000 rupees per mask. So these are the things that we are thinking of. We have not fully started our procedures as on now, but we are trying to figure out how we'll do it. Dr. Tanvi asks, post-traumatic scars, how early should we start any procedural treatment? It is said that the earlier you start, the better it is. Earlier, we used to think that we should let the scar settle down, but while the scar is forming, if you modulate the scar formation at that time, that's the best time. And it is said that if you interfere while the scar is forming, within maybe the first month or two of this formation of scar, you're going to get the best result in the ultimate outcome of the scar. Dr. Divya Malhotra, advantages of fractional erbium YAG over fractional CO2. If you have to do very precise work and superficial textural improvement in the pores, and you want to be very, very safe, then erbium YAG is the laser. But if you want to treat deeper, thicker scars and cause some tightening of the skin, coagulation of the skin, then CO2 is the answer. In general, we have seen that CO2 fractional gives us better results, and the fear and skepticism about use of fractional CO2 in our kinds of skin producing post-inflammatory pigmentation is fairly low. We don't see so much of PIH. Okay, Dr. Sonal, when is the earliest we can use laser on scars after trauma? I said the earlier the better. Don't let the scar form. As it is forming, modulate the formation and you will get a good outcome earlier. Earlier, it was thought that we should let the scar settle down and then treat, but now the latest belief is that the earlier the better. Also, combination of laser with scar revision. When shall we start laser at the earliest? As I said, do your scar revision as soon as the wound heals, which would be about 15 to 20 days or maybe 1 month, and then you start your laser. So if you start your laser at that time, the scar, while the scar is being laid down, it will be laid down in a proper manner rather than in a scarred manner. Dr. Sanjeev Chaudhary, will combining treatment laser MNRF with PRP help in acne scar management? A lot of people are combining PRP with resurfacing treatments, but evidence as of now shows only that PRP promotes post-operative healing. So if you had a downtime of about 7 to 10 days with CO2 laser, if you use PRP, they'll heal within 5 days. As on the if we consider the efficacy and outcome in the scar treatment, it has not been proven that PRP really improves the scars over and above when only CO2 laser or only MNRF is used. But it definitely improves the downtime and reduces the healing time. Dr. Kailash, what is your opinion regarding Energet during this COVID era? I think that should not be very harmful to use, but again, if you are working around the mouth, you will have to be careful to save yourself from aerosol. Dr. Sonal appreciates the session, says it was informative and great presentation. Thank you very much. Dr. Rupam, good evening. Dr. Rupam, what is the treatment of choice for post-trauma linear bulging scar on the chin in groove below lips? If you are talking about papular scar, like in acne, which happen in the perifollicular areas, they are compressible scars. They are known as papular scars, and they usually best respond to either a thin needle radio frequency done with a thin needle introduced into the center of the lesion, preferably with a insulated needle where you deliver the energy at the base of the papular scar, or you can even use a conventional CO2, a narrow beam, one beam you shoot at the center and it contracts. I don't know what you are talking about, whether you are talking about that, but post-trauma linear bulging scar, if it is a compressible scar, then this is the treatment. If it is not compressible and hard, then probably it can be treated as a hypertrophic scar. Okay, anonymous attendee says, for stria descensi, which gives good results, laser or dermapen? I think they are comparable, and dermapen has the advantage that they give you, along with the dermapen, they give you a cocktail of medication that can be, or mesotherapy therapeutic agents that can be applied along with the dermapen, which has an additional advantage of inducing fibroblasts, causing a little repigmentation, etc. So dermapen there has an advantage. If you would do a fractional resurfacing and use that meso solution on that, then the results would be comparable, I think. Dr. Leela Rani says, quite concise, informative talk. Thank you very much. Okay. Anonymous attendee. Okay, I think we have done with this. I'll go to the chat box and see if we have questions there. Okay. Okay, can you just tell us the site where we can get all the previous lectures? Okay, if you have missed any, okay. How useful are new fibrous plasma pens? I think we have answered this plasma pens. Do you use growth factor after procedure? What are the results? Yes, we do use growth factors, Dr. Ramesh. With the fractional devices, not only this but also with the derma roller or the derma pen, and I feel that that really adds, at least in healing, promoting the healing immediately after the treatment. How much it helps in the outcome, I'm not sure, but yes, it should help. They are growth factors do stimulate the fibroblasts to produce more collagen. You showed the keloid patient, would like to know the post procedure follow-up. This patient did fairly well. He had not responded to intralesional injection, so he had about 50% improvement when we introduced NFRF. So we did NFRF and intralesional tricot plus 5-fluorouracil plus Hylase in this patient, and about 50% improvement in about 3 sessions was seen. I don't have the long-term follow-up of the patient in this case. Can you name the cream? Which cream is he asking? Okay. Thank you, sir, for the great answers. Tanvi. Okay. Dr. Sarita, for accidental scar on forearm, of big length of 10 to 12 centimeters can be treated with CO2 laser, or surgical treatment should be advised? Okay, it will depend upon the width of the scar. If the scar is quite wide, then it's better, removed surgically, sent to a plastic surgeon for surgical resurfacing or removal. And then once the scar starts healing, then you do the CO2 fractional, and the combination of both will give you the best result. Okay, melasma. Oh, Dr. Rashmi Shetty, good evening. Periorbital skin, your approach please lacks aging skin. Okay, Dr. Rashmi, thank you for attending. For the periorbital skin, if I have to do a laser, I preferably do a sublative radio frequency treatment that really tightens the skin well, and gives a good textural improvement. But in the periorbital area, you have to actually decide what exactly is the cause of the periorbital pigmentation or periorbital uh, 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 sallowness, etc. So it can be thin skin, where for thin skin you may need fillers to improve the texture and color of the periorbital skin. It may be lax and wrinkled skin, where you would probably require a laser. It could be pigmented skin, where you would require something like a peel, or maybe a laser toning, which should be done carefully with an eye shield, etc. But once you have decided what exactly is the cause, then you can do your procedure, or you can combine all of them to get a good result. Is it advisable to test dose of Hyalase while treating keloid? I don't know. I have not done it, but none of my patients has had any problem with Hyalase. Please keep us posted if possible the results of Viora. Okay, Tanvi Kamor. Okay, I think we are done with the questions. Let me see the. Is there a difference in efficacy of cheap and expensive MNRF machines? I think definitely yes. I have had the opportunity of using both kinds, and I've seen that as I use the good machine, I definitely am finding the results to be better. So there has to be something in the machine which is important. Depends upon how much electric energy, what is the amount of energy traveling from one electrode to another electrode. It'll probably depend on that, the ultimate outcome. Is there a difference? Okay. For accidental scar of, I think we have answered this question. Hyalase we have answered. Burn scar with laser is better. So treatment of burn scar with laser is better. It'll depend upon what kind of scar it is. Any scar for that matter, you can't straight away give a blanket statement that laser treatment is better or surgical treatment is better. It will depend upon the scar. You have to look at an individual scar. First of all, if it is a burn scar, what kind? Is it atrophic, it's hypertrophic, or it is a keloid? Classify it, and then if it is in its initial stages of development, then probably some vascular laser like PDL will be very, very helpful. If it has evolved completely and it's become white, then probably intralesionals and fractional resurfacing will be available, will be useful. If it is very huge, then probably debulking it initially and then fractionating it and giving intralesionals will be useful. So each scar will require assessment before we do the treatment. Suicidal knife scars on the forearms are the most difficult things to treat. They do not respond most of the time. I have tried these lasers. Most of them do not do well. I'm trying out mesotherapy in them, but as of now, I have not got an answer to these scars. Dermapen or laser for stria? I think we have done it. Okay, Shriyal, if you can hear me.
Yes, Dr. Anil.
Okay, I think we are done with all the questions. And
yes,
Time is
So
also.
thank you very much. Very comprehensive presentation, very detailing. You've had a lot of patience to go through each and every question and comment that came into us. So thank you so much for all your time. Thank you all our attendees for joining us today. I would quickly take this opportunity to share an update on our next session. We would like to invite you to join an exciting webinar that our sister division, IDEX Healthcare, is hosting on Monday. That's 1st of June from 2 to 3 p.m. on integrating robust healthcare technologies and systems in your workplaces. I will be interviewing healthcare futurist Neil Mehta during the session. So block your calendars, Monday, June 1st, 2 p.m. You will receive an email from us with the registration link for the session. And we would also keep you updated with all the aesthetic medicine upcoming sessions in the week. Our next educational session that would be coming up would be on fillers by Dr. Amit Luthra. So we would keep you updated with the date and the timing, so you could join us on that as well. Like I've said, if you've missed any of our sessions, even today's session, if you joined in late, you want to see the session from the start, please log on to our website. It's aestheticmed.in, and you could get access to our sessions over there. Of course, the video takes you to our YouTube page, so do not forget to subscribe. We also regularly keep updating our Facebook and Instagram pages, so you could find us there with Aesthetic Medicine India. So you could follow us on Instagram, like us on Facebook, so you could just be there with us for all our sessions, dive in at the right time. Dr. Anil Ganjoo, thank you once again so much. It's been a pleasure having you with us today evening.
Thank you very much. I would like to thank you for this opportunity, and I would like to thank all the attendees who were very, very, proactive. Lots of questions. It was a real pleasure to answer all those questions. Also, thank you very much.
Definitely, definitely. So take care, stay safe, and we'll definitely meet soon, either virtually or once we out of this scenario. Definitely. Thank you so much. Take
Thank
care.
you very much.
Bye.
Thanks.